Good morning. I'm very excited to do this. Hopefully my excitement will show in my voice. My voice isn't so good right now, so hopefully it holds up. But I'm Jason Valent. I'm tasked with talking on, will I recognize amyloidosis when I see it? And as someone who is very passionate about amyloidosis, I would like to think that I will know amyloidosis when I see it, but in practice that has not happened all the time. So all of the cases that are going to be presented are real cases, and we'll highlight some of the pitfalls or successes in making the diagnosis. Those are my disclosures. So we wanted to talk a little bit about nomenclature. Historically, amyloidosis has been talked about, primary, secondary amyloidosis. We're not really using those terms anymore, so the nomenclature basically uses an A before the precursor protein. So a lot of what we see will be AL amyloidosis as hematologists. There will be patients that we think have AL amyloidosis that have transthyretin amyloidosis. So those are going to account for most of the cases of amyloidosis that we'll see, but there are a smattering of others. All right, so real-life patient, a 74-year-old Caucasian woman who developed painful paresthesias spreading distal to proximal in her legs. She, 6 months later, developed a bilateral foot drop, and that was followed by progressive lower and upper extremity weakness. 1 year later, she developed lower extremity edema, and her serum albumin was 1.7. She had a 20-kilogram weight loss over the course of 2 years. And if you suspect amyloidosis, what should you do now? And this is a best answer, so some of these actually are reasonable to do.
Read the choices.
Oh, sorry. So you should obtain an EMG as A, B is a routine urinalysis, C is serum free light chains and serum immunofixation, D is urine free light chains, and E is obtain an echocardiogram.
You say when you want them to do it.
I count to 20.
Okay. I think that's enough.
All right. I love your answers. So, what am I pointing at here? There we go. So, I would agree that obtaining serum free light chains and serum immunofixation would be the next best step. So it is not wrong to obtain an EMG. So she had absent sensory and motor responses in the right lower extremity. Her urinalysis on routine urinalysis showed greater than 300 milligrams per deciliter of protein. Urine-free light chains, I argue, is always the wrong answer in talking about plasma cell disorders. And her echocardiogram did not really show evidence for cardiac amyloidosis. So her intraventricular septum, left ventricular posterior wall, or 8 millimeters with a normal global peak longitudinal strain. So, I highlight this as best I can, but you get the most help in making the diagnosis of amyloidosis from the serum immunofixation and serum free light chain assay. So her free lambda was 73, her free kappa was 11. Her serum protein electrophoresis showed no M protein. Her serum immunofixation showed a faint IgA lambda. And the 24-hour urine protein electrophoresis and immunofixation showed 9 grams of protein in 24 hours with 74% albumin without a quantifiable M protein, but the immunofixation did show an IgA lambda. All right, so making her diagnosis. Her bone marrow biopsy showed 10% plasma cells with amyloid deposition in her vessel walls and in the marrow space. She had a T1114 translocation, and her abdominal fat pad biopsy was positive by immunohistochemistry with lambda and negative with kappa and transthyretin. So the take-home point, I think, from this case is neuropathy can be difficult. So actually, this woman was told by her primary care doctor that she had a conversion disorder and that she could get up and walk whenever she wanted, but she had a psychiatric condition. She was told that for almost 2 years, despite a serum albumin of 1.7. So it's hard to diagnose the amyloid from neuropathy alone, but neuropathy is often a presenting symptom. In her case, the low serum albumin with a nephrotic proteinuria was certainly a significant clue. I think anybody, and I'll come back to this, one of my favorite sayings is that proteinuria is always pathologic. Okay, we shouldn't have significant protein in our urine. So that kind of abnormality in a serum albumin, let alone looking at the urine of 1.7, gives a great clue in her case. All right, so this is used with permission. This is the only patient that I'll use a name and a picture. So sometimes the amyloid is very obvious, and Wayne is a great example of this. So very healthy, very fit, personal trainer. So he is basically the most amazing physical specimen I've ever seen. He noticed he had dyspnea when he was doing his cardio workouts, and he was told he had asthma by his primary care doc for 6 months. And his symptoms over the course, they progressed relatively quickly. So he noted abdominal bloating, which was really just edema, and he felt like he was losing muscle mass. So he had, as part of his evaluation, eventually an echocardiogram, which showed significant left ventricular thickening. So the septum was 1.9 centimeters, posterior wall 1.8 centimeters, and his global peak longitudinal strain was minus 6%. We're going to talk about strain a little more at the end of this, but abnormal global peak longitudinal strain is a very, very strong indicator that there could be cardiac amyloidosis. His NT-proBNP was markedly elevated. His troponin was abnormal, and he had 6.1 grams of protein in 24 hours with 79% albumin. His free lambda was 717 with a normal free kappa. And Dr. Zonder yells at me for saying this, but in this patient, the troponin elevation with this light chain is AL amyloidosis until proven otherwise. He did have an endomyocardial biopsy that ended up confirming the diagnosis of lambda AL amyloidosis. So he's a great guy, a wonderful human being, and I like to personalize his case because he wants his case personalized. He wants people to know that, yes, a 30-year-old, 36-year-old can have AL amyloidosis, and that shouldn't be ignored. So some patients are not quite as obvious. So this was a 79-year-old who I met and diagnosed with smoldering multiple myeloma. So had basically testing done because he had a mild neutropenia and thrombocytopenia, completely unrelated. His kappa was 723 and his lambda was 18. And I actually checked his NT-proBNP when I first saw him. It was 167, normal being less than 450 for his age in our lab. And that was not followed with testing at regular intervals. So unfortunately, MGUS and smoldering myeloma don't always progress to myeloma because for my patient 6 years later, he developed a pericardial effusion. And his pericardial biopsy shows amyloidosis involving the small arteries and epipericardial fat. His immunohistochemical staining was inconclusive for kappa, lambda, and transthyretin, but his mass spectrometry confirmed kappa immunoglobulin light chains. His NT-proBNP, after the pericardial effusion was drained, was 7,000. And his kappa had essentially stayed stable over those 6 years. So I always describe his case as one of the most humiliating cases for me because I missed his amyloidosis at some point. This diagnosis could have been made somewhere between 0 and 6 years before he really was symptomatic. So what was very obvious from his EKG, so the top tracing is his EKG from 6 years prior. The bottom EKG is his tracing after drainage of the pericardial effusion. So this isn't low voltage from the effusion. But his voltage significantly dropped from 6 years prior to where he was now. And so my big question is what can we do in these patients with significantly elevated light chains to follow them? So his free light chains certainly suggested that there could be AL amyloidosis. How do we monitor patients with smoldering myeloma or MGUS with this light chain elevation to ensure that we're not missing developing AL amyloidosis? And so in the United States, I'd love to order an NT-proBNP and troponin on every patient I see with a light chain abnormality. We can't do that because the diagnosis of MGUS, multiple myeloma, or AL amyloidosis is not covered to order an NT-proBNP or troponin. So I think I'd love to hear what the panel does with this because I've been in this conundrum where I will order it if I'll say to the patient, hey, do you ever feel short of breath? Do you ever have an abnormal breathing? Because those are diagnosis codes that are covered. But it can be hard to justify ordering the NT-proBNP and troponin. All right, so I love talking about serum-free light chains because serum-free light chains are key in diagnosing AL amyloidosis. But light chains don't always tell the whole story. So this was a 73-year-old black woman who her smartwatch started showing fluctuations in her pulse. So I don't wear a watch. I have smartwatches. But I've heard that they can actually measure heart rates and EKGs and things like that. So her pulse went from the 70s to 120. She would feel more short of breath and fatigued when she was tachycardic, but didn't actually notice the sensation of palpitation. She had no edema, and her EKG showed AFib. She was started on anticoagulation and a beta blocker, and she comes to see me. She was sinus bradycardia with a first-degree AV block. So we did evaluation for AL amyloidosis, which included serum immunofixation with an IgG kappa monoclonal protein, serum protein electrophoresis showing 0.6 grams of monoclonal protein, a free kappa of 114, a lambda of 8.1. Bone marrow showed 10% plasma cells and was negative for amyloidosis, and her echocardiogram showed significant left ventricular wall thickening with a normal ejection fraction. Her NT-proBNP was abnormal with a troponin that was undetectable. All right, so what should you do now? A is a fat pad aspirate or biopsy. B is a cardiac MRI. C is a technetium pyrophosphate scan. Or D is get yourself a new smartwatch. There may not be a wrong answer here. Again, it's a best answer. This is good. Excellent. Somebody wants a new smartwatch? Come on. All right, so my bias on the best answer is a fat pad aspirate and biopsy because tissue is going to be an issue with this patient. So this is similar to solid tumor oncology. Her fat pad biopsy was negative. She had a technetium pyrophosphate scan which showed grade 2 uptake. So for those who are smarter than me in cardiology, this will be talked about, but grade 2 uptake is somewhat equivocal on a technetium pyrophosphate scan. She did end up having an endomyocardial biopsy, which was positive with transthyretin by immunohistochemistry and negative for kappa and lambda. She ultimately went on to have genetic testing, which showed a pathologic mutation in transthyretin gene. So this was a woman who obviously had cardiac amyloidosis by biopsy, but again, her light chains didn't tell the whole story. So I think it's important, and we'll talk about the diagnosis here in just a minute of cardiac amyloidosis. But it's important to get tissue. So yes, there are many patients that we suspect amyloidosis or suspect AL amyloidosis, but you never want to give somebody chemotherapy if they don't have AL amyloidosis. If they have ATTR amyloidosis, treatments are very different. They're very effective now. So I think it's a very important point. Yes, the technetium pyrophosphate scan helps, but in someone with an abnormal light chain who has a positive or equivocal pyrophosphate scan, very, very important to get tissue. So the tissue diagnosis can often be made not biopsying a heart or a kidney. So we generally start with a fat pad biopsy. At our institution, fat aspirates had a terrible yield, so we stopped doing them. Minor salivary gland can be very helpful. But the point I'll make is it's not wrong to biopsy a heart or a kidney. So if you want to biopsy the suspected organ, you're in the hands of people who know how to do this. It's not wrong to do it. Just to get the tissue whichever way you need to. Immunofluorescence is not perfect, but usually will help, or usually will make the diagnosis of a light chain or transthyretin amyloidosis. The gold standard is laser microdissection and tandem mass spectrometry. Dr. Zonder asked me to go into details about how that's done, and I basically flat out refused. So he can tackle me and throw me off the podium if he'd like to, but I'm not a pathologist. It's a lot of lines on a paper, and the pathologists thankfully tell me what the protein of origin is. All right, so a few more pearls. I think there are several scenarios when you should always think about amyloidosis. And that's the patient with heart failure with preserved ejection fraction, particularly if they don't have a history of hypertension. And the real selling point here is the hypotensive patient. So somebody with a systolic blood pressure of 90, a wall thickness of 1.5, amyloidosis, and think about it. Nephrotic proteinuria always should warrant a free light chain test. Unexplained neuropathies, certainly sensory, motor, or autonomic, and I think autonomic neuropathy is overlooked in terms of the diagnosis of amyloidosis. And I was asked to include tongue enlargement because it is essentially pathognomonic but somewhat rare. I think you can sometimes think about amyloid when you have these symptoms, so bruising or bleeding, particularly periorbital purpura. That should be on the last slide. Periorbital purpura should be always to think about amyloidosis. Unexplained alkaline phosphatase elevations, heart failure with reduced ejection fraction, but a lack of epicardial coronary disease. Subacute progression of renal failure or diarrhea or symptoms of malabsorption. All right. So a little bit more on cardiac amyloid, because cardiac amyloid is what ultimately often determines mortality. So there are a lot of clues. So this is a 45-year-old, 65-kilogram man who ran a marathon a year ago. He had progressive dyspnea on exertion. His serum and urine immunofixation were negative for a monoclonal protein. He had a lambda of 155 and a kappa of 11, and had 1.45 grams of protein in a 24-hour urine with 81% albumin. So this was truly his EKG. He had low voltage, particularly in his limb leads, a pseudoinfarct pattern in the anteroseptal leads, poor R-wave progression. So could this be amyloidosis? The answer is absolutely. So what do we get from echo? So there's a number of imaging modalities that can be used, but echocardiogram shows wall thickening, the speckle pattern in the myocardium, and this is probably the best example I've ever seen. This was provided to me by one of our cardiologists. But the walls on the heart muscle on an echocardiogram should not appear white. It should be more gray. So this is the best example of a speckle pattern to the myocardium. And to the trained eye, it is obvious that both the septum and left ventricular posterior wall are thickened. I mentioned this a bit earlier, but the global peak longitudinal strain is a very good hint about amyloidosis. So strain is an echo imaging technique. Basically, the description of apical sparing on the longitudinal strain analysis can be a very important clue to the diagnosis of cardiac amyloidosis. And this goes for both AL and ATTR amyloid. So this is described by cardiologists that I work with as a cherry on top. It's actually the cherry on the bottom because the apex of the heart actually sits on the bottom. The technetium pyrophosphate scan. So very, very important at distinguishing between transthyretin and light chain amyloidosis. It's not perfect, but it's really, really good. So if you suspect transthyretin amyloidosis, technetium pyrophosphate scan is very reasonable to order. ATTR amyloid in the heart takes up technetium. And in a last resort, you can do cardiac MRI. So MR is very, very good at detecting infiltrative cardiomyopathies. So the T1 map and then what's referred to as late gadolinium enhancement are clues on the cardiac MRI to amyloidosis. So before I get run off the stage, I think the key take-home points: serum free light chains and serum immunofixation. Best test to screen for plasma cell disorders and AL amyloidosis. I will make a point that the light chains are not always markedly elevated. So some amyloid patients have a small clone. It's a very bad clone, but it doesn't take much of a bad thing to cause a problem. Not all the light chains are derived from plasma cells. I couldn't fit this into a 20-minute talk, but just know that the bone marrow biopsy is still important because there are a small percentage of patients who will have another B-cell malignant or another B-cell clone that makes light chains, and that can affect treatment. There are, again, many clues to cardiac amyloidosis. Some are very simple: EKG, echocardiogram, NT-proBNP, but one of the points the cardiologist that I work with makes is a static troponin elevation. So somebody has a troponin elevated, doesn't have to be very high, it just has to be elevated. Why is the troponin high? Why is it always up? Suspect cardiac amyloidosis. And then, again, the tissue biopsy, I think, is very important. Again, that does not have to it does not always have to be from the organ that you suspect involvement, but getting a tissue diagnosis is very, very important.